Hello everyone and welcome to this new lecture. Today I will be reading to you this lecture about occlusion in complete denture. It would be an audio lecture and I will read it to you right away, starting with the occlusion in complete denture. What is the occlusion in complete denture? It must be known that occlusion in complete denture must be developed to function efficiently and with the least amount of trauma to the supporting tissue. Occlusion means to close. This word is used to describe the static contact relationship between the incising or masticating surfaces of the maxillary and the mandibular teeth or tooth. It is the static contact of teeth that exists after the jaw movements have stopped. It is the contact relationship of the upper and lower teeth. All occlusal forms should at least have a tripod contact eccentric relationship. Again, all occlusal forms should have at least have a tripod contact eccentric relation. Centric relation. What is centric relation? The occlusion, it is the occlusion of opposing teeth when the mandible is in centric relation. This may or may not coincide with maximum intercuspation. Centric relation is the most posterior relation of the lower to the upper jaw from which lateral movements can be made at a given vertical dimension. And it is the most protruded physiological relation of the mandible to the maxilla, to and from which the individual can make lateral movements. It is a condition that can exist at various degrees of jaw separation. Again, it is a condition that can exist at various degrees of jaw separation. It occurs around the terminal hinge axis and another thing about centric relation is that it is the most posterior relation of the mandible to the maxilla when the condyles are in the most posterior unstrained position in the glenoid fossa, from which lateral movements can be made at any given degree of jaw separation. Another point about centric relation is that the maxillomandibular relationship, in which the condyles articulate with the thinnest avascular portion of this respective discs with the complex in the anterior superior position against the shapes of the articulator eminence. Again, it is the maxillomandibular relationship in which the condyles articulate with the thinnest avascular portion of their respective discs with the complex in the anterior superior position against the shapes of the articular eminences. This position is independent of tooth contacts. It is restricted to a purely rotary movement about the transverse horizontal axis. It is a significant jaw position in prosthodontics and especially in complete denture construction. It is a significant jaw position in prosthodontics and especially in complete denture construction. It is a reproducible and recordable position which can be repeatedly arrived at and thus serves as a reliable guide to develop centric occlusion in complete dentures. Secondly, centric relation become starting point to plan and execute the occlusion. Third, centric relation is related to terminal hinge axis. In centric relation, condyles exhibit pure rotation without any translation. Fourth, this position is more definite than the vertical relation and is independent of the presence or absence of teeth. Fifth, the final act of masticatory stroke ends in centric relation. It is a functional position. Sixth, it is a border position and the posterior limit of the envelope of motion. The transverse horizontal axis, an imaginary line around which the mandible may rotate within the sagittal plane. Again, the transverse horizontal axis is an imaginary line around which the mandible may rotate within the sagittal plane. Maxillary intercuspal position is the complete intercuspation of the opposing teeth independent of the condylar position. Occlusal pattern is the form or design of the masticatory surfaces of a tooth or teeth based on natural or modified anatomic or non-anatomic teeth. Occlusal interference is any tooth contact that inhibits the remaining occluding surfaces from achieving stable and harmonious contacts. Articulation refers to the static and dynamic contact relationship of maxillary and mandibular teeth as they move against each other during function. Free mandibular movement is any mandibular movement without interference. Balanced between parentheses is called balanced. Occlusion. It refers to the bilateral, simultaneous anterior and posterior occlusion contact of teeth in centric and eccentric position. Objectives of this relation. The basic principles to be achieved by an occlusion concept are preservation of the remaining tissues, proper masticatory efficiency, enhancement of denture stability, and enhancement of phonetics and aesthetics. Difference between natural and Artificial occlusion. What is the difference between natural and artificial occlusion? First, the teeth in natural dentitions are retained by periodical tissues that are uniquely innervated and structured. In complete artificial occlusion, all the teeth are on bases seated on slippery tissues. Second, in natural dentitions, the teeth receive individual pressure of occlusion and can move independently. Third, malocclusion of natural teeth may be uneventful for years. Fourth, non-vertical forces on natural teeth during function affect only the teeth involved and are usually well tolerated. Whereas in artificial teeth, the effect involved all the teeth on the bases. It is usually traumatic to the supporting structures. Fifth, incising with natural teeth does not affect the posterior teeth. Incising with artificial teeth, however, affects all of the teeth on the base. Sixth, in natural teeth, the second molar is the favored area for masticating hard food. Again, in natural teeth, the second molar is the favored area for masticating hard foods. Seventh, in natural teeth, bilateral balance is rarely found. If present, it is considered balancing side interference. Eighth, in natural teeth, proprioception gives the neuromuscular system control during function. Moving on to the fundamentals for artificial occlusion. The smaller the area of occlusal surface acting on food, the smaller will be the crushing force the food transmitted to the supporting structures. Second, vertical force applied to an inclined occlusal surface causes non-vertical force on the denture base. Third, vertical force applied to a denture base supported by yielding tissue causes the base to slide when the force is not centered on the base. Fourth, vertical force applied outside lateral to the ridge crest creates tipping force on the base. Requirement of complete denture occlusion. First, stability of the denture and its occlusion when the mandible is in both centric and eccentric relations. Second, balanced for all centric contacts, bilaterally for all eccentric mandibular movements. Third, unlocking, removing interference, the cusps mesiodistally so that the denture can settle down when there is ridge resorption. Fourth, control of horizontal forces by buccolingual cusp height reduction according to the residual ridge, resistance, and interridge space. Fifth, functional lever balance by favorable tooth to ridge crest position. Sixth, cutting and shearing efficiency of the occlusal surface, sharp cusps or ridges. Seventh, anterior clearance of teeth during mastication. Minimum occlusal contact between the upper and lower teeth to reduce pressure during function. Lingualized occlusion between parentheses. Concepts of occlusion. There is no scientific proof that any one concept of occlusion will satisfy all of the requirements of complete denture in all patients. Also, there is no scientific proof that one tooth form is more efficient than other tooth forms. Number one, spherical concept of occlusion. Monozone, between parentheses, purposed that the lower teeth move over the surface of upper teeth as over a surface of sphere with a diameter of 8 inches. The center of the sphere is located in the region of glabella. The surface of the sphere passed through the glenoid fossa and along with the articulating eminences. According to this concept, the anterior, posterior, and mediodistal incline of artificial teeth should be arranged in harmony with a spherical surface. Number two, organic concept of occlusion. The aim of this concept is to relate the occlusal surface of the teeth so that the teeth are in harmony with the muscles and joints during function. The muscle and joint determine the mandibular position of occlusion without any tooth guidance. So the muscle and joints should determine the mandibular position of occlusion without tooth guidance. The mandibular position of occlusion is terminal hinge position. In function, the teeth should always be passive to the paths of mandibular movement. Third, or number three, neurocentric concept of occlusion. According to this concept, the anterior-posterior plane of occlusion should be flat and parallel to the residual alveolar ridge, and not dictated by the horizontal condylar guidance. The form of posterior teeth is devoid of cusp, and there is no projection above or below the occlusal plane. This concept is similar to the monoplane occlusion used to set non-anatomical teeth. Occlusion in complete denture. Types of occlusion. Balanced occlusion, number one, and number two, monoplane occlusion. Number three, lingualized occlusion. In balanced occlusion, The complete denture can be defined as the simultaneous contacting of the maxillary and mandibular teeth on the right and left side and in the posterior and anterior occlusion areas, in centric and eccentric positions, developed to lessen or limit tipping or rotating of denture bases in relation to the supporting structures. Bilateral balanced occlusion. This is a type of occlusion that is seen when a simultaneous contact occurs on both sides in centric and eccentric positions. Bilateral balanced occlusion helps to distribute the occlusal load evenly across the arch and therefore helps to improve stability of the denture during centric, eccentric, or parafunctional movements. Protrusive balanced occlusion. This type of balanced occlusion is present when the mandible moves in a forward direction and the occlusal contacts are smooth and simultaneous anteriorly and posteriorly. There should be at least 3 points of contact in the occlusal plane, 2 located posteriorly and 1 anteriorly. Absent in natural dentition. Lateral balanced occlusion. In lateral balance, there will be a minimal simultaneous 3-point contact present during lateral movement of the mandible. This is absent in natural dentition. Teeth should be arranged such that there is simultaneous tooth contact in balancing side and working side. Parts of the occlusal scheme. Occlusal scheme has 3 units. Number 1, incising units. Number 2, working units. And number 3, occlusion balancing units. Incising units include all the 4 incisors. A. These units should be sharp in order to cut efficiently. B. The unit should not contact during mastication, except during protrusion. They should have as flat an incisal guidance as possible considering aesthetic and phonetics. D. They should have horizontal overlap to allow for base settling without interference. E. They should contact only during protrusive incising function. Working units include the canines and the posterior teeth of the side towards which the mandible moves. A. They should be efficient in cutting and grinding. B. They should have decreased buccal lingual width. To minimize the work force directed to the denture foundation. C. They should function as a group with simultaneous harmonious contacts at the end of the chewing cycle and during eccentric extrusion. D. The occlusal load should be directed to the anterior-posterior center of the denture. E. Plane should be parallel to mean foundation of the ridge. Balancing units includes canines and posterior teeth opposing the working side. They should contact on the second molars when the incising unit contact in function. B. They should contact at the end of the chewing cycle when the working unit contact. C. They should have smooth gliding contacts for lateral and protrusive extrusions. In natural teeth, when the mandible is protruded so that the incisal edges of the upper and lower teeth contact, there is a gap between the upper and lower posterior teeth. This is termed Kristin's phenomenon. Factors affecting balanced occlusion. Laws of articulation. Hanau Quint. There are 5 factors involved in eccentric occlusal balance in complete dentures. First is condylar guidance. The second, incisal guidance. The third, the occlusal plane. The fourth is the compensatory curves. The fifth is the cusp angulation, relative cusp height. The first is condylar guidance. The angle between the protrusive condylar path down the eminence between parentheses and the horizontal reference plane. It is definite anatomical feature that depends on the inclination of the floor of the glenoid fossa. It should be determined on the patient and set on the articulator by eccentric records, so that the patient's TMJ is in harmony with the occlusion programmed on the articulator. The steeper the condylar guidance, the more separation of the teeth that will occur when the mandibular moves in protrusive or lateral movements. Christensen's phenomena. If the condylar angle between the path of the condyle and Frankfurt horizontal plane is steep, it's difficult to produce balance occlusion. Because when the condyle travels downward and forward, large space is created posteriorly when the anterior teeth are edge to edge. So compensation should be made by altering the other factors to obtain the desired balance. It is the only factor which can be recorded from the patient. The dentist has no control over the condylar inclination and cannot change or modify it to fit particular occlusion. Components of condylar guidance. Horizontal condylar guidance guides the forward movement for protrusive balance. Lateral condylar guidance guides the sideward or lateral movement of the mandible. Second, we have the incisal guidance, defined as the influence of the contacting surfaces of the mandibular and maxillary anterior teeth on mandibular movements. During protrusive movements, mandibular teeth move downward and forward, called as incisal guidance. Incisal guidance influenced by aesthetic, phonetic, ridge relations, arch shape, and interridge space. If the incisal guidance is steep cusps or occlusion plane or steep compensatory curve is needed to balance occlusion. It is determined by the dentists and customized during anterior try-in. Desired overjet and overbite are determined. If overjet is increased, the inclination of incisal guidance is decreased. Incisal guide angle should be acute with suitable vertical overlap and horizontal overlap to achieve balanced occlusion. Components of incisal guidance include horizontal component overjet and vertical component overbite. Number 3, plane of occlusion or occlusal plane, defined as an imaginary surface which is related anatomically to the cranium and which theoretically touches the incisal edges of the incisors and the tips of the occluding surfaces of the posterior teeth. It represents the mean curvature of the surface. So, the occlusal plane is established in the anterior by the height of the lower cuspid, which is nearly coincident with the commissure of the mouth, and in the posterior by the height of the retromolar pad. It is also related to the ala tragus line. It should be nearly parallel to the ridges, raising the occlusal plane in the posterior will minimize the vertical separation of the teeth in eccentric movement and aid in balancing denture occlusion. Tilting of the plane more than 10 degrees is not advisable. Number 4, compensating curve. The anterior, posterior, and lateral curvatures in the alignment of the occluding surfaces and incisal edges of artificial teeth, which are used to develop balanced occlusion. Determined by inclination of posterior teeth and their vertical relationship to occlusal plane, there are two types of curves. A. Anterior-posterior compensating curve, curve of Spee. Anatomic curvature of the occlusal alignment of teeth, beginning at the tip of lower canine and following the buccal cusps of the natural premolars and the molars, continuing to the anterior border of the ramus, as described by Graf von Spee. When the patient moves his mandible forward, the posterior teeth set on this curve will continue to remain in contact, thus avoiding this occlusion. B. Mediolateral compensating curve of Wilson. It's a part of compensating curve extends mediolaterally from one side of the arch to the other side. This curve compensates the opening that occurs when lateral movement of mandibular jaw is made. The curvature in a frontal plane through the cusp tips of both the right and left molars. C. Compensating curve of Monson or Monson curve. The curve of occlusion in which each cusp and incisal edge touches to a segment of the sphere of 8 in diameter with its center at glabella. Number 5. Cuspal angulation. Angle made by the average slope of a cusp with the cuspal plane measured mediodistally or buccolingually. It's an important factor that modifies the effect of plane of occlusion and the compensating curves. Mediodistal cusps are reduced to prevent the locking of cusps. In shallow bite cases, cuspal angle should be reduced to balance the incisal guidance. In deep bite cases with steep incisal guidance, the jaw separation is more during protrusion. Teeth with high cuspal inclines are required for these cases. Interaction of the 5 factors. Of the 4 that the dentists can control, 2 of them, the incisal guidance and the plane of occlusion, can be altered only a slight amount because of aesthetic and physiologic factors. The important working factors for the dentist to manipulate are the compensating curve and the inclinations of cusp on the occlusal surfaces of the teeth. Types of posterior teeth. An anatomic tooth is one that is designed to stimulate the natural tooth form. The standard anatomic tooth has inclines on approximately 33 degrees or more. When the cusp incline is less steep than the conventional anatomic tooth of 33, it can be classified as a modified or semi-anatomic tooth. It can be considered basically anatomic and will articulate in 3 dimensions. Number 2, a non-anatomic tooth. It's flat and has no cusp heights to interdigitate with an opposing tooth, and has solvency to enhance its communicating effects on food. They articulate in only 2 dimensions. Selection of posterior teeth forms. Factors affecting the selection of posterior teeth forms. The capacity of the ridge to receive and resist forces of mastication. Inner ridge distance. Ridge relationship. Aesthetics. Patient's age and neuromuscular coordination. Requirements of balanced occlusion. Number 1. All the teeth on the working side should glide evenly against the opposing teeth. Number 2. No single tooth should produce any interference or disocclusion of the other teeth. Number 3. There should be contacts in the balancing side, but they should not interfere with the smooth gliding movements of the working side. Number 4. There should be simultaneous contact during protrusion. General considerations for balanced occlusion. Number 1. The wider and larger the ridge and the teeth closer to the ridge, the greater the level balance. Number 2. Conversely, the smaller and narrower the ridge and the farther the teeth from the ridge, the poorer the level balance. Number 3. Wider the ridge and narrower the teeth buccolingually, greater the balance. Number 4. The more lingual inside the teeth are placed in relation to the ridge crest, the greater the balance. Number 5. The more centered the force of occlusion anterior-posteriorly, the greater the stability of the base. Number 6. Previous denture wearing experience. Advantages of balanced occlusion. Distribution of load, stability, reduced trauma, functional movement, efficiency, and comfort. Disadvantage of balanced occlusion. More occlusal disharmony during setting of teeth and difficulty to correct by adjustments. Stable base and precise jaw closer is required. increased horizontal force due to the presence of inclined plane of the cusps, difficulty to adapt in jaw relation other than class 1. Evaluation. There is ideas questioning the validity of balanced occlusion in full denture from the point of view that during rest position, teeth are not in contact. During chewing the food, during chewing of the food, separating the teeth. So balanced articulation appears to be more important when no food in the mouth. It may be of value in non-functional activities when the patient is bruxing. Significance. Normal individual makes masticatory tooth contact only for 10 minutes in one day compared to 4 hours of total contact during other functions. So, for these 4 hours of tooth contact, balanced occlusion is important to maintain denture stability. Prime gave the concept of interbolus exit balance, which implies that introducing of food on one side will prevent the teeth of opposite side from contacting, and hence occlusal balance is impossible during mastication. However, Shepard later gave the concept interbalance, according to which even while chewing, the teeth cut through the bolus and come in contact with each other for a few fractions of a second. Hence, the stability of the denture is maintained during various movements of mandibular during chewing. Normal individual makes masticatory tooth contact only 10 minutes in one day compared to 4 hours of total contact during other functions. So, for 4 hours of contact, balanced occlusion is important to maintain denture stability. It's important to stability of denture, reduce resorption of the residual ridge and soreness, and improve oral comfort and well-being of the patient. Balanced occlusion with non-anatomic or flat teeth. Balanced occlusion with cuspless teeth can be achieved by several ways. 1. 0-degree teeth with inclination of the lower second molar, tilting the second molar. 0-degree teeth with balancing ramps and balance posterior to the most distal molar. 0-degree teeth set to steep compensatory. Monoplane or non-balanced articulation. It is also called neurocentric occlusion. Neurocentric occlusion. In this type of occlusion, the concept of occlusion assumes that the anterior-posterior shape of occlusion should be parallel to the denture foundation area, and not dictated by condylar inclination. The plane of occlusion is completely flat and level. There is no curve of Wilson or curve of Spee, no compensating curves incorporated into the setup. There is no vertical overlap of the anterior teeth. When setting these teeth, the horizontal and lateral condylar guidances should be set at 0. Non-anatomical cuspless teeth 0 degree are used. The occlusal plane flat and parallel to the upper and lower residual ridges. No compensating curves are created. The teeth are set flat with no medial or lateral inclination. Elimination of inclined plane, therefore more stability. The patient is instructed to avoid incising with anterior teeth to avoid displacement of the denture. The teeth are arranged without vertical overlap. The buccolingual width of the teeth is reduced. The number of teeth is reduced to direct the forces in the molar and bicuspid area of support to avoid placing a tooth on the ridge incline in the second molar area. With this concept of occlusion, there is no attempt to eliminate deflective occlusal contacts in lateral or protrusive excursions. The condylar inclinations of the articula are set to 0 degrees. When the foundation tissues is compromised, an example is severely resorbed ridge, knife edge, thin wiry ridge, or one that covered with thick movable flabby tissues. Favorable control of occlusal forces can be utilized by the set of non-anatomic teeth arranged following the monoplane occlusal concept. Indications of the monoplane occlusion or the neurocentric concept. Flat ridges, class 2 jaw relations, class 3 jaw relations, maxillofacial patients, handicapped patients, cross bite, doubtful or without any perfect centric relation records. Advantages of monoplane neurocentric occlusion. Simple and less time consuming, less precise jaw relation records. Lateral forces are reduced by eliminating neutralizing cusp inclines. Simpler and easier occlusal adjustments. Occlusion is not locked. Good for patients with class 2 retrognathic, class 3 prognathic, and crossbite ridge relations. For the geriatric patients is also considered an indication. Disadvantages of neurocentric occlusion includes least aesthetic, poor bolus penetration, cannot be balanced in eccentric excursions, lingualized occlusion. The lingualized occlusion concept is a variation of the bilateral balanced occlusion concept. The premolars and molars are arranged so that only the lingual cusps of the upper posterior teeth make contact with the center fossa of the lower posterior teeth. This type of occlusion involves the use of a large upper palatal cusp against wide lower central fossa. The buccal cusps of the upper and lower teeth do not contact each other. It is identified by the occlusal contacts of the maxillary lingual cusps of the posterior teeth initially with the occlusal surfaces of the mandibular teeth in maximum intercuspation, and the continuous contacts of the lingual cusps with mandibular teeth during various movements of the mandible. This concept also can be considered as a balanced articulation. The teeth are anatomical or semi-anatomical teeth with some modifications. Number 1 modification, sharp maxillary lingual cusp in the posterior teeth opposing a widened central fossa on the occlusal surface of the mandibular antagonists is maximum intercuspation and in the buccal cusp is out of occlusion. Number 2, mandibular teeth have a reduced facial and lingual cusps and widened central fossa. Advantages of lingualized occlusion: aesthetic, better penetrating of food bolus, decrease of vertical and lateral forces, simpler technique, less precise records, usually in a wider variety of patients. Added stability is gained during parafunctional movements with a balanced occlusion. Easier to adjust occlusion. May be used in class 2, 3, and crossbite. May be used to incorporate many of the advantages but few of disadvantages of other schemes. For the dentures that we have mentioned before, we have the anatomic, lingualized, and neurocentric. The denture stability during parafunctional movement is positive with anatomic, lingualized, and negative with neurocentric. For the simpler technique and less precise record, there is negative with anatomic, positive with lingualized, and neurocentric. decreased lateral forces, negative with anatomic, positive with lingualized, and neurocentric. Ease of adjustment, negative with anatomic, positive with lingualized, and neurocentric. Good for class 2-3 jaw relation, negative with anatomic, positive with lingualized, and neurocentric. For a better aesthetic, positive with anatomic and lingualized, negative with neurocentric. Ease of penetration, decreased vertical stress, positive with anatomic and lingualized, negative with neurocentric. Good stability, forces controllized and neutralized, negative with anatomic, positive with lingualized and neurocentric. Factors affecting the selection of the occlusion concepts. Age of the patient, condition of health, oral cavity, soft tissue and residual ridge, social status and demand of the patient, aesthetic and function, skill and physiology of the dentist in occlusion concept. The dentist must really rely on clinical skills and experience when selecting an occlusal scheme for the patient. The availability of the material and dental laboratory efficiency is also an indication. Factor affecting accurate start for denture occlusion. Accurate measurement of vertical dimension of occlusion, accurate recording of centric jaw relation. These two factors depend on skill of the dentist and the clinical judgment. 3. Properly constructed bite trim, strongly polished, smooth, round, equal thickness, border, resemble finished denture. In general, all complete denture occlusions have certain common factors in their design. For example, most occlusion requires that the teeth in the upper and lower dentures contacts in centric occlusion when the mandible is in centric jaw relation to the maxilla. Tooth contacts in this relationship are established to distribute stresses evenly over the entire denture base, supporting area to preserve the supporting structure that must carry the load during function. This was the lecture for today. Thank you for hearing it. It was about occlusion in complete denture.